Lakshmi, good to see you. You know that schizophrenia and bipolar disorder, two disorders we've spent a lot of our time on in our lives, are quite common and complex. But it can also be difficult sometimes to differentiate these disorders and other disorders, especially with bipolar disorder where depression is the core. How do you differentiate unipolar from bipolar depression? And I would like you to spend some time on how you would do that in a specialty setting, but also in the primary care setting, because 75% of antidepressants are actually prescribed there.
Absolutely. A great question, Christoph, because clinicians often struggle to make that distinction. And that's really one of the reasons why when you look at some of the studies, many patients with the bipolar disorder often are misdiagnosed as having major depressive disorder. And I think the reason is because depressive episodes are a feature of a major depressive disorder and also bipolar 1 disorder. And the symptoms of the depressive episodes in both conditions, as we know, can be very similar. And that's really what presents those diagnostic challenges. Now, there are some clinical features that can raise a high index of suspicion of bipolar disorder in a patient presenting with depressive symptoms. So these might include things like presence of psychotic symptoms as a part of depressive episode, reverse vegetative symptoms such as hypersomnia, hyperphagia, so sleeping too much, eating too much, tend to be more common as part of depressive episodes in bipolar patients. Family history of bipolar disorder, of course, is much more common in people with bipolar disorder. And there are other features such as early age at onset of the illness is more common in people with bipolar disorder, more episodes or recurrent episodes. And patients with bipolar depression tend to not respond to antidepressants as readily as those with MDD. So again, no one feature is pathognomonic or diagnostic. The more features are there, higher the index of suspicion of bipolar disorder. But the most definitive way to make that distinction in real-world clinical practice is really to screen for a previous hypomanic or manic episode, because without that, you cannot make that diagnosis, right? And I think one of the things that clinicians often do is ask for a period of elevated mood, which in a lot of patients with bipolar 1 or bipolar disorder who have had hypomanic or manic episodes, if you ask them, has there a period in your life when you felt unusually happy for no reason, a lot of people will say no. And if you conclude based on that you haven't had a hypomanic or manic episode, you will have missed that in many cases. So what I would recommend is ask questions that are much more sensitive in eliciting those previous episodes. And those are things like, has there a period when you felt that you had too much energy? Or has there a period when you felt that you could get away with less sleep than usual? Or has there been a period when you had too many thoughts going through your head? And if the patient acknowledges a period like that, then start asking an open-ended question such as, okay, tell me more about it. What else were you experiencing during that period? And if they're not forthcoming, then go with more specific questions, things like, during that period, did you have increase in sex drive? Did you spend more money than usual? Did you get into trouble legally? Those sorts of things. And I think you just need to go through that checklist of symptoms to ensure that they've had enough number of symptoms to meet the criteria for a hypomanic or manic episode. And also look for change in functioning or alteration functioning that also can give one a clue, I think. But that's the most definitive way to do it. But I would say, also look for those other features that raise high index of suspicion as well.
You're making a couple of very important points. People who are depressed may not remember how great they felt in the past, so you need much more to focus on these neurovegetative and specific signs that are much less common in depression. But depression can have also mixed features, And the speed of depression may also give us some hints. Can you maybe say something about that?
Yeah, so that's an interesting point, because the mixed features we now know, we used to believe that those are, mostly seen in people with bipolar depression, but now I think there's enough evidence to suggest that depressive episodes that are part of a major depressive episode can also have some mixed features, which again presents that diagnostic kind of a challenge as well. So I think clinically, one of the things that we tend to do is that we also often, as much as possible, involve a significant other. They might shed some light on this sort of thing. Very important. And in our clinic, as soon as we offer an appointment for a patient, we actually send them a mood disorders questionnaire. And we say to them, take your time to fill this questionnaire and make sure that you completed it before you come in for an appointment. And so if their appointment is in a month's time, they will have had enough time to think through their past and answer lots of those questions that really try to get at symptoms of a hypomanic or manic episode. So we don't necessarily use that as a diagnostic instrument. It's more of a screening kind of thing. So if they came in and if they ticked yes to any one or more of those things, we spend a lot more time trying to dig through the answers for those kinds of things to establish the previous hypomanic or manic episode.
I think that's a great suggestion for the audience. It's the mood disorder questionnaire, the MDQ, or the rapid mood screener. Both are freely available, and patients click or tick off basically the criteria for mania and hypomania. And if you have enough of these positive answers, you should dig into this. And it has even been used in primary care quite successfully.
Absolutely. I think the only thing that we just want to caution our clinicians is please make sure not to use that as a diagnostic instrument, right? It's a screener, and use that to spend more time looking for those episodes, I think.
Well, thank you very much.
Now, on that note, Christoph, I guess in clinical practice, one of the other conditions that people with the bipolar disorder often get misdiagnosed as is the psychosis or schizophrenia. Now, given your expertise in psychosis, what would you recommend to clinicians in terms of making that distinction?
Yeah, it's quite complex, because I've had, and most likely you too, people come in and they look so disorganized and so psychotic that you think this must be schizophrenia. But as they then respond to the psychosis, you see much more the mood driving this, and they can become more organized. And what seemed disorganized was actually very fast, rapid fire thinking, where you couldn't even follow all of the connected, almost literary connections of thoughts. And in that sense, I think, as we all know, psychiatric disorders are not cross-sectional diagnoses. You have to make them longitudinally and keep an open mind. Yeah. And it's on the other hand also that we might miss the disorder that has more mood component. And as you know, there's a lot of the schizoaffective disorder diagnosis, which may be a parking diagnosis because we can't make up our mind. And it's important to recognize that if you have 2 weeks of psychotic symptoms without any mood component, that's really relevant to distinguish schizophrenia or schizoaffective disorder from bipolar disorder. And bipolar disorder, you would have to have either depression or mania that drives or co-occurs with psychosis. But then on the other hand, to differentiate schizophrenia from schizoaffective disorder, it's not enough to have like a little bit of depression or mania-like symptoms. You need half of the disorder time spent in with mood problems. And I think that's where clinicians much too quickly jump onto the schizoaffective component here. Now, how will we treat it? We treat obviously psychosis and the mood component, but then you may not need the antipsychotic lifetime if you've made the right diagnosis that the psychosis always co-occurred with mood symptoms.
Yeah, so you make a very interesting point about the longitudinal part, right? Because especially people presenting with the first manic episode, often can have psychotic symptoms, and clinicians often struggle to make that distinction, right? Is a psychosis now part of the bipolar 1 manic episode, or is part of the psychosis that's part of schizophrenia, right? So,
and I think there's this old thinking, it has to be mood congruent. And
Right.
if it's mood incongruent, it has to be schizophrenia. No, it's not always the grandiose delusion that you have in bipolar
Exactly.
disorder. You can also become irritated and paranoid. So I think it's much more important to differentiate, is there a mood component when you have psychosis or not?
Yeah, so it sounds like you're saying that if you're unsure, it's okay to give that diagnosis psychosis and wait and see how the symptoms or course evolves before assigning a diagnosis schizophrenia or bipolar 1 disorder.
Absolutely.
Wonderful. Pleasure. Thanks very much.
Thank you.